Inguinal hernia in under 5 minutes. A short tutorial for Discover Pediatric Surgery by Andrew Grieve, Karen Mulford, and Nirav Patel. Most inguinal hernias in children are indirect inguinal hernias that result from failure of the processus vaginalis to close. Direct hernias that result from medial wall weakness and femoral hernias do occur in children, but they are rare. The main risk factors for indirect inguinal hernia are prematurity, male sex, family history, and undescended testes. Indirect inguinal hernias are also more frequently found in children with ventricular peritoneal shunts, cystic fibrosis, and those undergoing peritoneal dialysis. In order to understand what an inguinal hernia is, some understanding of embryology is necessary. During intrauterine life, the gonads in both males and females descend from their retroperitoneal origin at the urogenital ridge. In males, this descent carries the gonad through the inguinal canal into the scrotum. During this process, a diverticulum of peritoneum is carried with the gonad. This diverticulum is known as the processus vaginalis. In females, although gonadal descent terminates in the pelvis, the ovary is anchored to the labia by the round ligament. The round ligament passes through the inguinal canal to form this point of fixation, and it too is enveloped in a diverticulum of peritoneum. The processus vaginalis should close by term, but can remain open and either remain asymptomatic during an individual's lifetime, present as a communicating or encysted hydrocele in a male, present as a cyst of the canal of Nuck in a female, or present as an inguinal hernia. Essentially, an indirect inguinal hernia occurs when a patent processus vaginalis contains intestine or other abdominal organs, whilst the hydrocele occurs when the patent processus vaginalis contains peritoneal fluid. The diagnosis of an inguinal hernia is based on history and clinical examination. Ultrasound is neither sensitive nor specific in children and should not be part of routine investigation. Parents may report an intermittent swelling in their child's groin. Young children are usually examined in the supine position. The groin should be inspected for any obvious swelling, and if not immediately evident, the patient can be asked to cough or blow against the hand. If a swelling is noted, it must be distinguished from a hydrocele. On history, hernias are more likely to appear and then disappear, especially when children are crying or straining. Swelling due to a hydrocele, on the other hand, is usually always present. On examination, it is not possible to palpate above a hernia, whereas this is possible with a hydrocele. Additionally, inguinal hernias can be associated with thickness of the cord on the affected side. This finding is not noted with hydrocele. Clinical suspicion of an inguinal hernia on history or physical examination is sufficient to warrant further management. Management is always surgical. The risks of surgery may be thought of as minor and major. Minor risks include pain, scarring, bleeding, and wound infection, whilst major risks include recurrence and, in male patients, injury to the vas or the testes. Remember to counsel parents that the absolute risk of surgery is low and that surgery is indicated due to the high lifetime risk of incarceration. Timing of hernia repair depends on patient characteristics and presenting features, with incarcerated hernias requiring emergency treatment, preterm children and those with a history suggestive of incarceration requiring urgent treatment, and all asymptomatic and older children elective management. In those patients undergoing elective repair, always remember to counsel parents on the danger signs and symptoms of incarceration, including vomiting, a painful red or hard hernia, or a distended tummy. Should parents notice any of these danger signs or symptoms, they should take their child to the nearest health facility immediately. In certain instances, bilateral hernia repair may be indicated. These instances include premature infants with a left-sided inguinal hernia, females under the age of 2, and children with a high risk for anesthesia. Bilateral hernia repair can be done open or laparoscopically, though laparoscopy is the gold standard for bilateral herniatomy. Surgery is usually performed by means of a small incision on the groin for those children undergoing open herniatomy, and these patients usually return to normal activity within 3 to 4 days. If parents notice any danger signs including fever or vomiting, severe tummy pain, excessive redness, discharge or bleeding from the wound, or excessive groin swelling, they should return for immediate review. In those children with no danger signs, dressings can be removed after 4 days and the child can bath normally. Follow-up may be performed telephonically for uncomplicated cases. Thanks for listening, and please visit the Surgeons for Little Lives website or the Discover Pediatric Surgery podcast to download this and similar tutorials for free.